So it's the most common neurological condition affecting young adults. It's characterized by the degeneration and loss of myelin scattered throughout the central nervous system, as well as impacted the oligodendroglea, which is the support structure in the central nervous system. So some of the signs and symptoms that you may see with these patients could vary depending on where their demyelination is occurring. The etiology is really unknown, but it's thought to be an abnormal autoimmune response that triggers an inflammatory process and damages the myelin sheath of neurons. So the signs and symptoms can develop slowly over weeks or days, or it could develop very rapidly over hours. Some of the most common symptoms that can occur for MS is fatigue, muscle weakness, paresthesia, which is what?
Numbness and tingling.
Tingling, thank you. Unsteady gait, double vision, which is called what? Thank you. Tremor, a bladder or bowel dysfunction, dysphagia, which is dysarthria, which is okay. Cognitive impairments and ataxia. So the most important symptoms to monitor with these patients is fatigue and heat. Okay? So a lot of times people that have MS may actually seek alternate climates versus down here in the south where it's quite warm, and may choose to move to cooler weather areas. So the primary fatigue, also known as lassitude, which is a result of demyelinization and poor conduction. So some of their fatigue they cannot control. So be mindful of that when you're pushing your patient, okay? So there is this primary fatigue that they cannot control. It is due to the demyelinization and the poor nerve conduction. Secondary fatigue is caused by deconditioning, poor sleep hygiene, inadequate nutrition, and infections. Do you think maybe that the primary fatigue might result in secondary fatigue? Yes. So your role is to re-examine and report findings to the PT. So if you see something that's changed in the patient, then you definitely need to report that to your physical therapist. You want to monitor those signs and symptoms and report the changes to the PT. And provide intervention per your plan of care. So this is a picture of what demyelinization would look like to the right. It talks about the tingling pain, and that's that paresthesia. I actually have a patient that has MS right now, and I've been treating him for a while, and he has primary progressive, so it's just going to continue to get worse. And he's 20 years old, 27 or 28. And his typically, it looks as if it affects his basal ganglion more so than anything else. He's got very ataxic movement patterns. And heat does play a role. He came in one day and me and the PT could both tell that he was much worse than he had been. And we found out that he went for a walk with his aunt out in the heat the day before. So he stays inside most of the time to stay away from the heat. So this is the exact chart that's in your book. There's different types of MS. There's benign, so there's no disability and they return to their normal level of function between attacks. There's relapsing remitting MS, which they never get a new disability in between attacks, but it does slowly progress. And then there's primary progressive multiple sclerosis. That is no new disability between attacks followed by steady increase in the disability. And then of course there's primary progressive, which is what I talked about, where there's a steady increase in disability without any attacks. So monitoring those patients for new onset of symptoms is really important too. The most common is relapsing remitting. Okay, so for MS, the exercise says regular exercise 2 to 3 sessions per week. This is on that other, I put it on that, remember I put it on the other slide by accident. 65 to 75% of max heart rate, 20 to 30 minute sessions, 1 to 3 reps with 15 to 18 reps per session with a goal of increasing to 3 or 4 sets. Is a 12-week program. And this is for someone that has mild to moderate disability within this, okay? So other treatments for spasticity would include stretching, application of cold, electrotherapeutic agents, use of orthotics, you would improve their balance and postural control. Of course, you educate them on staying out of the heat. You know, patients are not always compliant, as with my little fella. But, I mean, you can't tell them that they can't just not live their life either. So, you can't be mad at us for wanting to go for a walk. Compensate for impaired sensation. Y'all, we've talked about that a lot. What would that look like? So, say they have paresthesia and their sensation is, their tactile sensation is impaired. How would we teach them to compensate for that? What would we train elsewhere to help with that? Speak. Visual system.
Yeah, visual system.
Okay, what's another one? Vestibular system. Right. So discuss with the PTA about referrals that may be needed to medical different appropriate medical professionals. So if you see like a change in function, what you might have to do is tell your PT so that they can go make an appointment for their neurologist, right? So that they can go let their neurologist know that, hey, we've seen a progression in their symptoms. They may need to be reassessed. They may need a neuro workup. Can't remember which is which. I should put descriptors by these.
You know what it's like when plaque psoriasis makes you hide your skin under sleeves. To have a turtleneck choking you in 92 degrees. You know what it's like to go through treatment.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss multiple sclerosis. Multiple sclerosis, or MS, is a central nervous system disorder that involves the abrupt appearance of neurological symptoms, which usually occur for the first time between the ages of 20 and 50. The symptoms of MS vary from person to person, and almost any nervous system function can be disrupted in the disease. The most common initial symptoms involve visual disturbances, abnormal sensations, and weakness. The causes of the disease are not fully understood and are thought to involve genetic and environmental factors. Multiple sclerosis is characterized by damage to the myelin sheaths surrounding the axons of neurons in the central nervous system. This myelin damage disrupts the conduction of action potentials along these axons, which is thought to cause many of the symptoms of the disease. The myelin damage can also lead to the deterioration of axons. The brains of MS patients can contain evidence of this damage in the form of plaques or lesions that are visible with some types of neuroimaging. The reason these attacks on a patient's myelin occur is not fully understood, but the damage in MS is most commonly attributed to an autoimmune attack. According to this hypothesis, the immune system in a patient with MS targets myelin, treating it as foreign. This autoimmune attack and the associated inflammatory response leads to damage to myelin, axons, and glial cells. What prompts the autoimmune attack is not known, however, and some have argued that MS is caused by a persistent infection instead. Either way, MS seems to involve excessive immune system activation in some respect, and the drugs that have proven most successful in treating it act to reduce inflammatory or other immune responses.
Somebody could figure out how to effectively treat
Welcome to 2-Minute Neuroscience, where I simplistic
inflammation in the body. They would make a lot of money. Like, get rid of it.
Life was good.
That's just a fella, you can watch that later. It's just a...
Ataxia is described as a lack of muscle control and lack of coordination during mobility
She's a
and
PT
movement.
that specializes
This
in
is
treating MS
often
patients.
due to damage of the spinal cord and damage to the cerebellum, which is often the place that multiple sclerosis attacks. Therefore, if you have an ataxic gait, this might mean that you walk with a widened stance, or you walk with irregular foot placement, or maybe even the step length is different every time you take a step forward. This often leads to a safety issue because it can actually cause you to trip or fall. Fortunately, there are general guidelines and exercises that you can implement into your day-to-day life to help you regain some of this control over ataxic gait.
She has other videos too. Good.
There are 3 main guidelines to follow in order to help you regain some sense of control over your mobility on a day-to-day basis. The first is to do one thing at a time. Therefore, try your best not to multitask. The second is to make sure you are stable once you stand up before moving to perform a task. So if you're getting up to go get a drink of water, make sure you stand up, then sense that stability before taking a step forward. If you move too quickly, that can make ataxia worse. And third, focus on quality over speed. We have a tendency to try to do things a little too fast, which can make ataxia worse. So focus on the quality of your movement instead of the speed of your movement. If you haven't met me yet, welcome to my page. I am Dr. Gretchen Hawley, physical therapist and multiple sclerosis certified specialist. I am the developer of The Missing Link, my online MS wellness program, and the new podcast, The Missing Link. If you're interested in checking out any of those, check the comments below. For now, I want to show you my 7 favorite exercises to help with ataxia. 3 of them are going to be seated and 4 of them are standing. So let's jump in. The first exercise is to lift one heel, then lower it down, and repeat the same on the other side. So you're sitting towards the end of the chair, or even in the middle of your chair, up nice and tall, core muscles nice and tight, and you're going to slowly lift one heel as high as you can, then slowly lower. Then the same thing on the other leg. Lift that heel and slowly down. Keep repeating this movement on each side, slow and steady. This is a great way to work some coordination into your practice. If you can't lift that high, that's okay. Just lift as high as you can comfortably and do as many repetitions with good quality as possible. The next exercise is one that requires coordination for walking. What you're going to do is lift one leg up as high as you can and then tap the knee with your opposite hand. So it looks like this: up and tap, down, up, tap, down. So you're going to be able to move in this alternating pattern. This is the same type of coordination that we need when we're walking forward. Similar to the heel lifts, it doesn't matter how high you are lifting your leg. If you can only lift your leg an inch off the ground, that's okay. Just reach a little bit further with your arms. You're also sitting up nice and tall. Core muscles are tight. So this alternating hand to knee.
Okay, so if you have a high level patient, how could you also do alternating movements? Think about that developmental progression that we've talked about.
Could they close their eyes? Like if they were doing that one?
Yeah, they could. I'm talking about in a different position.
Standing.
So you can do it in standing, but that's walking, right? What would also produce alternating movements in a different position? Think about quadruped and crawling, right? That's alternating movements.
Bird dog. Modified bird dog.
Yeah. Okay, sorry. I just want to continue to give y'all good ideas.
Exercise. To make that a little bit more functional, we're going to add an arm swing. So the third exercise is still the marching component, but instead of adding your hand to the knee, we are actually going to be pumping our arms. So when we walk forward, we need to be able to move one leg forward at the same time as the opposite arm. So that's what we're going to practice. So we're sitting down, our muscles are tight, sitting up tall. As you lift your left leg up, your right arm comes forward, then down. Then right leg comes up, left arm comes forward, and down. Start slow with this to make sure that you actually are lifting opposite. So right leg, left arm, down. Once you have the coordination, then you can go a little bit faster. This can be extremely tricky, so make sure you're checking in with yourself the entire time. I will say it's very common for my clients to start off correct, and somehow they get out of whack. And it's the same arm and same leg lifting, such as what I'm demonstrating right now. If that happens, stop, regroup, and then continue the opposite motion. Same thing here as what I said before. It doesn't matter how high you can lift your leg or even your arm. You're just trying to get this alternating motion. The next exercise is standing up, getting stable, then sitting back down. So you're going to be sitting at the edge of your chair, feet are nice and wide, and you bend your knees slightly. You can have your arms forward to help with momentum. And you're going to hinge and stand up. Then I want you to feel steady, feel like you are in control. Then hinge and slowly sit down. Now notice that my shoulders stay forward until my butt touches. Then I sit up tall. If you're the type of person that has a tendency to flop backwards like that, it's likely because you're keeping your shoulders too far backwards. So make sure you keep your shoulders forward.
Or nose
Let's
over
repeat that again.
toes.
You're sitting up
Another way
tall,
of viewing.
knees are nice and wide. They're also bent. Shoulders and arms forward. Hinge, stand up, stable, hinge, sit down, up tall. So let's do that again. Up, get stable, hinge, and down. You will use this a lot throughout the day. Anytime you stand up to do anything, You should be using this technique and feel stable before taking a step to move on to what you're going to do. We now have 3 standing exercises. I like to do these in the corner of the room so that I feel stable and can reach to either wall in case I need it. The first exercise is to stand with your hips shoulder distance apart, and you're just going to step forward and then back. You can hold on to something if you need balance. You can use a cane, you can use a walker or a rollator, or just hold on to the countertop. But you're going to shift your weight, then step forward, and back. Then same thing on the other side. Shift your weight off of the leg, then move the leg forward and back.
You see how hers are
Shift your weight
simplified? We're
forward,
not thinking about isolated
back.
muscle bellies at this point, we're
Shift.
thinking about movement patterns.
Forward,
Okay?
back. Again, we are working on this coordination movement while keeping our core muscles tight. It also requires weight shifting. If you forget to shift your body weight first, then you go to lift your leg, you likely will feel like you have to quickly put it down. So shift your weight, then move your leg. Next is using a step to help.
So, how could you simplify this? Take out the step, right, and just do the weight shift. Okay?
With coordination and balance. I don't have stairs in this room. If you do have stairs, you can go to your stairwell and hold on to the banister in the wall, or 2 banisters. Whatever you have in your home will work nicely. You can use something as large as a regular single step, or something as small as a thin book. Whatever you can tolerate. Again, hold on to something to make sure you're safe, and you're going to place 1 foot up top and stay here for balance. And you're just going to balance in this position for as long as you can. Keep your core muscles tight, squeeze your glute muscles, and when you're ready, lower that leg back down to the ground, and then repeat on the other side. So you'll stay here in good posture for as long as you can. And down. The final exercise is to use our step again, but this time for a coordinated tapping movement. So you can still hold on for safety. You're going to shift your weight off of your leg, then tap the step. Down. Shift your weight, tap, down. Now remember, if this step is too high, use something that's not as high. It can be a book, it can be a planner, or maybe it's nothing.
How can we progress it forward?
Step all the way up.
To step up, right, and then step down, right? That adds way more weight shifting, way more thought and control.
If you remove this step, this is the same exercise as the first standing one that we did, where you're just shifting your weight and tapping your foot forward. This is a progressed version of that same exercise. Shift, tap, down. Try to do each of these exercises for about 1 minute if you can tolerate it. But
Okay, so she has other videos with exercises on it that are helpful if y'all want good examples of good exercises to do with your patients that have neurodegenerative diseases. Y'all are always asking me for examples, so I thought I would give you a video of examples. Okay, Guillain-Barré, we've also talked about. A small event. So it's an acute inflammatory demyelinating condition that results in motor and sensory deficits. It has a rapid progressive onset with ascending symmetrical muscle weakness, areflexia, and mild sensory motor weakness. It affects males more than females, and the disability can be long-term in some cases, and it can also present with cognitive or psychosocial issues. So the etiology is suspected to be from a bacteria or a virus that it initiates the process. The demyelination in Guillain-Barré is thought to be a result of an autoimmune reaction after coming into contact with that bacteria or virus. There's a couple in your book that they talk about the different types of viruses. And the reason why we talked about this, the Guillain-Barré earlier, is because it's considered a lower motor neuron. And a good example of why that would be is, look, we're areflexive, right? So your book says it is an inflammatory process involving antibody mediated demyelination triggers that macrophages, which are the little parts of your outside of the cell that eat up bad things, okay? To release products that degrade the myelin at the nodes of Rampierre, which is the divots between the myelin sheaths, okay? The Schwann cells of the axons are mainly attacked and destroyed. So some of the symptoms of Guillain-Barré is the same as MS. We have that paresthesia in your toes or sensory symptoms followed by progressive symmetrical motor loss. It can impact your speech or your swallow. You can have autonomic dysfunction, sensory deficits, sleep disturbances, anxiety, and respiratory failure. So there's a few types of Guillain-Barré. Actually, we never learned this in school. So take it with a grain of salt. Acute inflammatory demyelinating polyradiculoneuropathy. This is the most common in developed countries. Then there's acute motor axonal neuropathy, and then acute motor sensory axonal neuropathy. Then there is Miller-Fisher syndrome, and this is a specific type of Guillain-Barré that is characterized by primarily affecting the cranial nerves and having ocular disturbances. We did learn about that.
So do we need to know those different types, like above the Miller-Fisher?
Honestly, I don't know that they would, I don't think that will be tested in the sense of like your board exam. I think you just need to know the basics of what Guillain-Barré is. Now, they may say Miller-Fisher syndrome, and you need to know that might be connected to Guillain-Barré, because I did learn that. But the types of Guillain-Barré, I would have to look those up if I had a patient with Guillain-Barré.
So would you still?
No. It's in your book, though. I think it's just helpful to know that there are types, and if you do encounter Guillain-Barré and they say this long name associated with it, that you know that that's probably the type that they have. So, Guillain-Barré happens in 3 phases. Progressive phase, the plateau phase, and the recovery phase. So, these are in your book on page 367. So the progression phase, it lasts for 1 to 4 weeks, and it is characteristic of the individual losing sensory and motor function. During this phase, the main goal is the medical team is to reduce the progression and eliminate respiratory involvement. Once other diagnoses have been ruled out, the individual may undergo a plasmapheresis and intravenous immunoglobulin therapies. So once that progression has stabilized and the individual is no longer experiencing that sensory or motor function loss, they hit the plateau stage. And that's a period where the individual is neither declining or improving. And once the individual begins to have improvement of sensory and motor function, then they are in the recovery phase.
Did you do plasmapheresis and intravenous hemoglobin? Did you do more than just those photos?
Honestly, I wouldn't think that they would, once it plateaus, they're no longer treating the autoimmune response. At that point, the autoimmune response has been stopped. So I wouldn't think that they would progress. And that they could. But okay, so the treatment for Guillain-Barré, of course, would, in the beginning, when they're, a lot of times these patients end up in ICU on vents regardless of, if the ones that you're gonna see typically in an acute or inpatient setting would have probably required some, they've had severe loss of function. So you're gonna concentrate on the range of motion of the patient and making sure you maintain joint mobility. Then you're going to go through and progress them through isometrics, isotonics with low resistance, progressive resistance, and then moving into TheraBand and free weights. You'll want to test their sensation over time because in order to know if they move through the phases right, we need to know, do neuro checks and make sure that, you know, if they are progressing, they're going to gain that sensory input again. So monitoring that along with nursing, because nursing does neuro checks for the physician. So there's several people looking at this. Functional mobility. Obviously, you have to be mindful of their medical stability when moving those patients, and knowing if it's appropriate based off of their labs and their vital signs. So family and patient education. Guillain-Barré can just happen out of the daggum blue. I mean, they could be a healthy person walking around and had a really bad ear infection, and this prompted an outbreak of Guillain-Barré. A lot of times, it can be related to vaccinations, can prompt it too. That's why that's one of the, when you sign your life away when you get a vaccination, this is like one of the risks of it, is developing Guillain-Barré. So I've seen both happen. It's really weird that I've seen Guillain-Barré a lot because they say it doesn't happen quite often, but I've had at least a handful of Guillain-Barré patients. So, interesting enough. And Kayra had a really bad case. Y'all met Kayra. She had a really bad case. Guy was 34 and had it to the point that, I mean, he was bedridden. Still, an inpatient, and they had just progressed him to the tilt table before they had to transition him. I don't know if he ended up going to another facility or if he went home. I don't know the extent of it, but he was starting to get returned, and his blood pressure was starting to stabilize more. But basically, that's what they spent their whole time doing, is trying to increase increase the stability of the patient. So that's why positioning is important, right? All that positioning that she did and making sure that our joints are in good positions and that we're not sitting on our arms or our legs, and making sure things are in a proper posturing while sitting in a bed. Making sure that they're being turned every couple of hours. Gentle stretching, positioning, management for pain too, pain management. And then those NDT movements, cycling, and then postural and balance training as they get better, as they progress through that last phase or stage. All these phases and stages, woo. So you don't want to increase the intensity and over-exercise your patient. So you want to make sure that they're medically stable for your treatment. One very good way of doing that is to check their vital signs. Okay? And look at their labs. Okay. Epilepsy. There's nothing in your book on epilepsy, and I just got lazy. So I put up the Mayo Clinic. So epilepsy is a seizure disorder. Most of you know that. It is only diagnosed if you've had 2 unprovoked seizures at least 24 hours apart. So the way that they can treat it is through medication or surgery to control the seizures. Sometimes people can require lifelong treatment. And sometimes children can outgrow epilepsy the older that they get. So some of the symptoms that you can have is the temporary confusion, staring spells, stiff muscles, uncontrollable jerking, movements of arms and legs, loss of consciousness or awareness, and psychological symptoms such as fear, anxiety, and deja vu. People that have this staring spell are absent. They're called absent seizures. So some people, in fact, there was a student that I went to school with that was in the class above me. They figured out she was having them. And it was because she would be writing her notes and her classmates would be further along in the notes, and she would have a big gap in time before she picked up again. So she was missing parts of her notes because she was having absent seizures. No. They just, yeah, stare off. They look away. They don't have any of the other jerking or any of that. They just miss points in time. And I'm assuming it could look like they have some type of amnesia, but they don't. They just are having absent seizures. So if your patient is just staring off into the abyss and not paying attention and not responding to you, they could be having absent seizures. So be mindful of that.
Can you like bring them back?
What now?
Can you like bring them back and be like, hey, and will they come back?
In my,
You gotta let it pass.
yeah. You have to let all seizures kind of die. So they changed the way, and I feel like this is important, and this is kind of why I put this website up here. They changed the way they like categorize seizures now. Like it's not like grand mal, what was the other one? Something mal seizures. There's different types when it came to the seizure activity, but now they just call them either focal seizures without loss of consciousness or focal seizures with impaired awareness. Then there's generalized seizures, where there's absent seizures, like I talked about, tonic seizures, atonic seizures, which is exactly exactly what it means. Tonic means what? Yeah, and atonic means, clonic seizures, which is repeated jerking. You remember myoclonus, when I told you what myoclonus was? Think of that, myoclonic seizures. And then tonic-clonic seizures. So that's how they categorize them now. Which is very different from what it used to be. So a lot of times they tell you not to worry about them, but you definitely want to call for help if you have someone having a seizure. So a lot of times in our facility, we have a procedure, it's called a rapid response where we are. So we'll call a rapid response overhead to the gym if someone's having seizure activity. But like, if you're in home health, you might have to call an ambulance over to assess the patient after they've had it. Or if they're epileptic, like they already have multiple seizures, then you might just have to, report it to their physician. So what can cause it? So sometimes epilepsy can run in families. It can be caused by head trauma, like if you've had a car accident or a traumatic brain injury. So brain tumors can cause epilepsy. This is when I see it mostly in our place, is when there's been trauma. Like if there's been stroke, or if there's a tumor, or they've had TBI of some sort, then a lot of times they'll have seizure activity afterwards that we have to mitigate. I've seen a few like unknown etiology seizure activity, where patients have come in and had them despite nothing really being wrong with them otherwise. So people with ADHD or people that have autism develop this. My daughter is, she had a febrile seizure and she has ADHD. So, I've always had to watch out for that with her. And then her uncle also has ADHD and he's had 2 seizures. So.
Does anything like trigger, like when they have ADHD, does anything trigger like a seizure for them?
Honestly, I don't know what the research says as far as that goes.
Do you think some triggers your daughter?
What now?
Do you think some triggers your daughter when she?
Well, it was febrile at that point, so it was resulted from an ear infection. She had fever, a really high fever, and it was atonic, like she just went completely limp on my sister. But I have worried about that with her, and because I know it can be that she's at a higher risk of having it. And then my husband has ADHD, but so does his brother, and he's had 2 seizures. Now one of them was from a head injury, so I don't know if the last seizure he had could have been a result from that too, or it could be a result of ADHD. It's his brain, which I think is what may have triggered him at that point. So, yep. And I've had elderly patients that have never had a seizure in their life just all of a sudden have a seizure and not know why it's occurring. So, yeah.
I had a really good friend growing up for a long time that had the grand mal seizures.
And those typically last longer than, I think, was it 10 or 15 minutes?
His were like, he was on Lamictal, and so his lasted like 5 to 10 minutes.
5 to 10, yeah.
And if he missed a dose, he could like tell it was coming. He would like say something like, I think I'm probably gonna have a seizure soon. And it would happen
Yeah.
at some point.
And his brother has said the same. He said he had the same sensation after he hit his head as he had when he had Kent's course, his mom freaked out and called me over there, but he, post-tictal, a lot of times, which is after seizure, they'll become agitated, be disoriented, not know where they're at or what they were doing. What happened to them? Yeah. So technically, my daughter she has a history of a seizure, but it's not a seizure disorder because she had it with a fever, and febrile seizures are actually pretty common with what she had at that point, which was an infection called roseola. So, if you've ever heard of fist disease, which is hand, foot, mouth, mamas or women, most guys don't know this. But roseola is sixth disease, so it's another skin like rash occurring. Oh yeah, and most kids under the age of 1 have had it, but it just causes a really, really, really high fever. But from what I've been told by a lot of pediatricians, it's not necessarily the high fever that causes it, it's the rapid onset of the high fever. So it's going from a fever of 98 to 102 quickly. So that's kind of what got my daughter at that point. Is she had that ear infection and she had roseola at the same time. She got a double whammy. I think her fever was like 105. And I mean, she had Tylenol. I mean, we had done everything we could, but she was napping, which can make them hotter. Yeah. So, I just felt bad for my poor sister.
She panicked.
Oh, yes. Very much so. So complications can be, you can fall when you have them. You can have sleep disturbances. You can have car accidents if you're driving and you're not supposed to be. You can drown if you're swimming and you have to. So all these things can happen if you have a seizure. I would. Okay. So the most important thing for you to know is the types of seizures, okay? And then, symptoms of the seizures.
30 chairs, non-squeak. 15 non-wobbly. Imagine you went for a walk inside your brain. You look to your right to see some nerve cells or neurons busy doing their work moving your arm. You look to your left and you see some other neurons thinking about what you'll be having for dinner later tonight. And all of a sudden, you hear a loud noise. You turn your head to see some neurons arguing together, refusing to do their assigned tasks and shouting loudly all at the same time. What's that? That's exactly what happens during an epileptic seizure. Epilepsy is a neurological disorder affecting more than 50 million people worldwide, and it's defined as the occurrence of multiple seizures due to malfunction of some neurons in the brain, causing them to fire synchronously. But what's a seizure? Let's go back to the basics. If we take a look at any neuron in the brain, we'll find two types of neurons acting on it to control its function. The first one is called an excitatory neuron, that when fires, activates the neighboring nerve cells. While the second is called an inhibitory neuron, and when it fires, it stops those neurons from working. And these two different types of neurons work together in a balanced manner to coordinate the work of other nerve cells. Neurons in the brain communicate with each other through chemicals known as neurotransmitters. And so, the excitatory neurons release excitatory neurotransmitters as glutamate, while the inhibitory neurons release inhibitory neurotransmitters as GABA. So what happens during a seizure is one of two things. Either the excitatory neurons fire more than needed, or the inhibitory neurons fire less than usual. And both situations cause other neurons to fire more than they normally would. And while the neuronal error is usually quite the same, the seizure itself can have multiple different presentations. For example, if the neurons malfunction and overfire in one localized area of the brain, the seizure appears on the body part controlled by it, like unintentional arm movement or even perception of a weird smell, and these would be called a focal seizure. However, if the neuronal malfunction spreads across the brain or is already all over the brain from the start, the seizure shows all over the body. And this may present in multiple different ways. The most common is the tonic-clonic seizure, also known as grand mal, which presents as loss of consciousness and muscle tension, followed by rhythmic muscle contractions all over the body. But also, children sometimes present by what's known as absence seizure or petit mal, where a child all of a sudden pauses, then goes back to what they were doing without even remembering that a seizure happened. There are multiple different causes of epilepsy, from genetic disorders to tumors, trauma, or even brain infection. Yet, in most of the cases, the cause remains unknown. And that's why the treatment usually aims mainly at controlling the seizures, which is done primarily using medications known as anti-epileptic drugs. Anti-epileptic drugs work in multiple different ways, such as enhancing the function of inhibitory neurons by increasing the production of GABA and amplifying its action, while some other drugs suppress the action of excitatory neurons by blocking the glutamate receptors or action sites. And both of these mechanisms prevent the neurons from rapid repetitive firing. However, epilepsy can also be treated surgically, when a specific cause for the seizures has been identified, such as a tumor, or when the seizures are of the focal type and the neurons causing the disease are located. And finally, with recent technological advances, a device called responsive neurostimulator has been used to treat patients with epilepsy not responding to drug treatment. The device is implanted within the brain and continuously monitors the activity of the neurons. And when it senses an increase in neuronal firing, the device produces an electrical impulse, resetting the neurons and preventing the seizure before it even happens. Epilepsy is one of the most common neurological disorders, and that's why it's important for all of us to know how to act if we see someone having a seizure. All you have to do is put that person in recovery position and make sure to time the duration. And if it continues beyond 5 minutes, quickly call an ambulance. Never put anything in their mouth and move any sharp object away. Stay calm till the seizure ends and reassure them that everything's going to be okay.
So that's a pretty cool way of seeing what that means on a cellular level, like what's happening in the brain in order to cause the seizure. I'm always intuitively want to know what's causing this. So generalized, you see the picture here where we're impacting the whole brain. Focal is where we impact a small part. So this is also not in your textbook, but cerebellar disorders. So they are disorders that have numerous etiology and different presentation, and most, of course, the lesion would be in the cerebellum. So there is congenital malformations that manifest early in life and that are non-progressive. So those hereditary ataxias can be Friedreich's ataxia. This is most common. The symptoms include unsteadiness that begins in early life, dysarthria, paresis, impaired cognition, slight tremors, impaired reflexes, impaired vibration, and impaired proprioception. And I've actually had patients, one, my whole career in 10 years with Friedreich's ataxia. And then spinocerebellar ataxia. This is both central and peripheral nervous system. The symptoms that could include neuropathy, ataxia, restless leg syndrome, hyperreflexia, weakness, spasticity, and a Babinski sign. And then there's acquired ataxias. These are neurodegenerative system disorders from toxin exposure, or it can be idiopathic. So some of the system disorders could result due to alcoholism, hypothyroidism, or vitamin E deficiency. Toxins that can cause this can be carbon monoxide, your heavy metals, or lithium. So, who takes lithium? You know?
Is that, not disassociative, what's the other
Major depressive disorder a lot of times, or bipolar disorder is another word for it. Major depressive disorder and bipolar are the same thing. But yeah, they take lithium, so if they take a lot of lithium over time, then you can see how it can impact and cause some ataxic movement patterns. And you've heard of like tardive dyskinesia, right, being caused by medications, especially psychosocial drugs that are antipsychotics, basically, can cause it.
These are separate from, these are their own thing.
Cerebellar disorders.
I mean, the circumstances. Like, can they be presented in people with, Parkinson's or something, or?
Well, ataxia is ataxia.
Yeah, but you wouldn't have.
But if you had ataxia plus all these other things, then you're more likely to have this.
So you could have Parkinson's and say spinal or ataxia. On top of it, ataxia.
I mean, it would be kind of rare, I would think. Well, the hereditary one is Friedreich's ataxia. Spinocerebellar ataxia wouldn't necessarily be hereditary. It could be developed. Okay, Alzheimer's disease. So this is a progressive neurological disorder that results in the deterioration and irreversible damage within the central nervous system. This damage is caused by amyloid plaques that fragment axons, they alter glial cells, and they cause cellular waste that triggers an inflammatory response. And that's why cerebral atrophy occurs during this disease process. The etiology is still unknown, but some hypothesize that the cause is due to lower levels of neurotransmitters, higher levels of aluminum within the brain tissue, a genetic inheritance, an autoimmune disease, abnormal processing of the substance amyloid, and viruses. It impacts women and those over the age of 80 at a higher rate. So really, to be honest with you, they don't know.
I didn't like what you said about Parkinson's, like they rule out everything else. Because I thought it was like something about how like you have to be, they can't really determine Alzheimer's until you pass. Or somebody, remember that?
Well, in a way, they can look at the cerebral atrophy from an imaging perspective, but until that you are autopsied, they can't really see the plaque.
Here's what it is.
Yeah. Okay. So symptomology progresses over time, starting with subtle changes in memory, impaired concentration, and difficulty with learning new things. Then towards the later part of the early stages, the patient develops the loss of orientation, they'll have difficulty finding words, their what is emotional ability? What does that mean?
Like being able to, like having being able to interpret emotions like that.
And handle their emotions.
Some days you may go in there and they're crying and completely inconsolable, and then 5 minutes later, they may be talking to you about the weather outside. So their emotions are like a roller coaster. They can't control their emotions. Depression, poor judgment, impaired ability to complete their ADA, because eventually these people just lose the ability to remember how to put on a shirt or how to put on pants. So the things that are rudimentary that we do daily and we learn how to do from a young age, they forget how to do them. So during the middle stages, the patient starts to present with aphasia, which is what? What are the two types of aphasia? Yes, which would mean expressive and receptive aphasia, right? Apraxia, which is so inability to use that premotor cortex to plan movement patterns. Perseveration. What is perseveration? Your toddlers do this. They perseverate. They persist in annoying the crap out of you. Don't they, Brittany? So they can't get their mind off something. That's like the little old lady that won't let go of the purse. Where's my purse at?
Or if you tell them toddler you want to take them somewhere.
And they just continually perseverate on it.
Until
right?
I answer a question, she's gonna ask it back to back to back. If I don't give her an answer.
That is called perseveration. And you should see my 5-year-old look at me and say, and I'm like, stop perseverating on that.
I'm gonna start using that.
What now?
I'm gonna start using that one.
Yes. What did she ask me last night? What the meaning of something was? Oh, I know what it was. I told her, because she would not help her dad pick up toys last night. And I was packing for our beach trip this weekend. And this yesterday was the only day I had time to do that. But she wouldn't help her dad pick up toys. And I told her that she would have consequences. I said, so she better, you know, there's repercussions for not doing what you're asked to do. And so she didn't. She went outside and played. So the repercussions were that she did not get help with her tablet. We did not turn it on. We did not put the password in. So there are consequences to your actions, my dear. So it's quite funny. I had a whole temper tantrum last night. But they can be violent. They can present with socially unacceptable behavior. They can be quite funny. During late end stages, the patient presents with severe intellectual and physical dysfunctions, and they may become incontinent. They'll be dependent for their care and their mobility. They'll be unable to speak, and they may have seizures. So you can see how it is progressive in the sense that over time we lose our ability to do anything.
What category of seizure would they have? Are theirs more focal or generalized?
I wouldn't think so, since Alzheimer's impacts the entire brain. I would think it would be more generalized. But I put a healthy control, and these are brain images of those who have Alzheimer's. So to me, although you can see a little bit of atrophy, it would be hard to discern on an image whether or not someone had Alzheimer's. So it's based off of symptomology.